Good afternoon, everyone. Welcome to the second day of the radiology course. Today's session is streamed live on the BGICC virtual platform of the 13th BGICC conference. For better visualization of the images, because we have many mammography and detailed illustrative images, please update your settings of the video streaming. You find it at the lower right of the video screen to 1080 settings, because this is the best resolution image for best visualization of our stream. Now, the streaming of the sessions of today will start.
Good afternoon, everyone. Welcome to our first session of the second day for the radiology course. I'm Merit Al-Madawi, and I will be moderating this session for you. This session duration is 2 hours, consists of 3 talks, followed by live discussion with our panelists and our guest speaker, Dr. Kulkarni, who is joining us now from Toronto, Canada. Dear attendee, if you have any question for our speakers at any time during any of the talk, please submit it into the chat box. You will find it as a red button in the lower right corner of your screen. And we will pass on your questions to our speakers and our panelists in the discussion time by the end of the session. Now, I'm honored to present our distinguished chairperson and panelist for this session, Professor Aisha Ramadan, Professor of Radiology, Faculty of Medicine, Azhar University, Professor Bahira Badran, Professor of Radiology, Faculty of Medicine, Azhar University, and Professor Sahar Mansour, Professor of Radiology, Women Imaging Unit, Al Asr Aini Hospital, Cairo University. Hope you all enjoy our session of the day. Dear Professor Aisha, you may start the session, please.
Good afternoon, dear colleague, audience, and all participants. First, I would like to thank all organizer committee for their effort and marvelous arrangement of this scientific committee of BGIC this year. And I thank Professor Rasha Kamal for inviting me to participate in this meeting. And it's a pleasure to welcome Professor Supriya Kulkarni for sharing our meeting. Professor Supriya, she is a breast division lead, Associate Professor, Joint Department of Medical Imaging, University of Toronto. She is the Education Director, Canadian Society of Breast Imaging. She is a Regional Breast Imaging Lead for the Toronto Central Regional Cancer Program. You're welcome, Professor Supriya, and please start your first talk. The first talk will be Pre-Operative Breast MRI. Please start, Professor Supriya.
Hello, everyone. I'm very happy to be here today to speak at the 13th BGICC conference in Egypt, and it's a very exciting time to be bringing this conference to all of you on a virtual platform, and to be speaking all the way from Canada to everybody in Egypt and across the whole world. So today I will be speaking about the use of breast MRI in preoperative staging, and we're going to go through this talk and discuss the appropriateness of utilization of breast MRI, as well as how we are going to use it in the preoperative staging scenario. So first of all, I have no disclosures. The objectives for today's talks are as follows. We're going to try to briefly understand the TNM staging, evaluate some goals of staging, why are we using staging, and then we will go over the historical overview of how the management of breast cancer has evolved over decades and where we stand now. And then we're going to look at some hard evidence for breast MRI staging and see how breast MRI performs in different scenarios, highlighting the controversies in breast MRI staging. So the purpose of staging is basically to assess the exact load of a tumor that exists within the breast, because this determines whether there is lymphovascular invasion or there is lymphatic spread in the axilla and beyond that. The AJCC 8th edition, which is the current edition of the staging manual, describes the T size as a prognostic size. It's the size of the largest tumor, invasive tumor focus that is existing in the breast. It talks about the largest invasive component, which means that it doesn't really include the size of DCS. This is one of the limitations. I would say that it does not include the size of DCS, and sometimes you can have a very locally advanced DCS involving a large volume of the breast, but that does not confer to the T size. T size is also important because it indicates the staging as well as the incidence of systemic recurrence. So it's a very important prognostic indicator of systemic recurrence. And then it is subdivided into T1, T2, T3, T4 based on the size of the invasive disease. Here is an example which shows you a unifocal invasive breast cancer. You can see it on the mammogram on the left lateral breast. This is how it looks on ultrasound. And MRI performed here in the sagittal view shows us a single large invasive breast cancer with some heterogeneity in the center. So this is a unifocal breast cancer. Another example of a unifocal breast cancer, which is fairly large in size. The size is at least T3 to T4. And you can see very classic MRI features of washout. And then you are also seeing the time curve, which shows a rapid uptake and then dropping suddenly within 2 minutes, which indicates a washout, indicating abnormal vessels. So this is a signature of a breast cancer. This is a very, very classic MRI features. Here is an interesting case of a woman who had a past history of gastric lymphoma, and she had radiation for her gastric lymphoma. So obviously, some of the radiation was given to the inferior aspect of the left breast inadvertently. And you can see that she now develops a palpable finding. And this is how it looks on ultrasound: an irregular hypoechoic soft tissue mass. A single lesion was demonstrated on ultrasound. And here is the MRI, which shows multifocal disease. So MRI really shows us the additional tumor extent with the breast cancer. As you can see in this case, she has multiple areas, and obviously the extent of the tumor that is seen on MRI is much larger than on other imaging modalities. Another example of extensive breast cancer involving the breast here, involving large volume, and this is the ultrasound image. You can see an abnormal axillary lymph node there, and you can see how in these multiple images of the breast MRI, we can document breast cancer much better. It is multifocal, multiple large areas. Involvement of the nipple is seen here, as well as a single large axillary lymph node in the level 1 position. So this is how we use MR. Here is a case of a locally advanced breast cancer where the entire breast has been replaced by these large necrotic enhancing tumor, which is involving the skin, is stuck to the pectoralis muscle. It is fungating and ulcerated and necrotic. So this is a locally advanced breast cancer. And we do use MRI for this, particularly in the setting of a neoadjuvant treatment protocol. So this is a locally advanced breast cancer. So basically MRI helps us to look for the overall extent, overall size, and helps us to decide whether this patient should go for breast conservation or a mastectomy. It tells us about the involvement of the surrounding structures, as I showed you in the previous case. And what is the importance of true extent? True extent of disease basically predicts local outcome, local recurrence, and what is going to happen to the surgical bed. So obviously, in a case of a locally advanced breast cancer, the local recurrence rates are quite high. And so MRI predicts this also for us. So that's the difference between T size and true extent. We need to understand. So T size is an indication of distant recurrence and staging, whereas the true extent is a local predictor of local recurrence and local outcome. Here's a nice case of a very dense breast tissue with a palpable finding in a high-risk individual who presented for her right breast, and you can see that she has a irregular hypoechoic mass, and in addition to that, you also see some hypoechoic tissue extending towards the nipple. So definitely it looked suspicious. When you look at the MRI, it's very clear the extent of disease is very nicely depicted on this axial and sagittal sequence, clearly performing way better than the mammography or ultrasound, which showed dense breast tissue. Another example of a dense breast tissue of a young person presenting with a palpable finding and some axillary lymph nodes. On ultrasound, you can see that it's an irregular hypoechoic mass, fairly large, but when you look at the MR, there's no doubt that there is locally advanced breast cancer involving the entire lateral and central breast. And you can say that the tumor is reaching up to the nipple and very closely involving the pectoralis muscle. So very elegantly shows the true extent of breast cancer. And here it is after neoadjuvant treatment where the tumor has completely melted. You still see some residual tumor here, but nevertheless, you can see that the extent of the disease is so less. And so this is going to be great for local control. The surgical outcome will be much better. The surgical bed will be much more sterile, and likelihood of recurrence in the surgical bed will be minimized. So this is the benefit of using neoadjuvant treatment, and MRI is definitely one of the key indicators of where it is performed. So this is one of the key indications. So the goals of staging are basically to determine the T size, the extent of disease, the lymph nodes, surrounding structures, and obviously contralateral cancer. So we looked at these examples already, and here is a case that presented for a staging of a mass in the left breast, and serendipitously, we detected some non-mass enhancement within the right breast, and obviously that underwent further imaging to reveal DCIS in the right breast, which was not detected before. What about the assessment of the lymph nodes? Lymph nodes help us measure 5-year survival. So there are many different indicators. So the lymph node involvement indicates 5-year survival. And we always like to know whether these lymph nodes are involved or not preoperatively, because the management changes. If they're negative, patient will proceed to sentinel lymph node biopsy. If the patient has a positive lymph node clinically or on fine needle aspiration on imaging, then there are many different considerations which really we can discuss now, but there is considerations whether the patient is going for neoadjuvant treatment, in which case they may need a clip, or how many sentinel lymph nodes were positive. According to the these Z11 trial, they may need further imaging, or they may need radiation if the lymph nodes are more than 3. So there are many different scenarios how lymph nodes are managed, and the lymph nodes are classified based on the pectoralis minor, the relationship with the pectoralis minor. Any lymph nodes that are lateral to the pec minor are called level 1 lymph nodes. Lymph nodes posterior to the pec minor are called the level 2 lymph nodes, and those that are located in the medial aspect of the pectoralis minor muscle are called level 3 lymph nodes. Internal mammary lymph nodes are considered to be a separate group, and so are the supraclavicular lymph nodes, which are considered as the high, kind of almost high level 3 lymph nodes. And then we also have intramammary lymph nodes, which for the sake of, for the purposes of staging, are considered to be level 1 lymph nodes, although their management can vary depending on the surgeon who may consider this to be an additional focus of disease within the breast. But nevertheless, as far as staging is considered, they are considered to be level 1. Here's a very nice example to show you these different groups of lymph nodes in a woman with fairly large breast cancer here. These are the level 1 lymph nodes, which are lateral to the pectoralis muscles. Again, you see it lateral to the pectoralis muscle. As we go further higher up, you start seeing the pectoralis minor. So these are the level 2 lymph nodes that are posterior to the pec minor, and these are the level 1. And as the lymph nodes start going medially, they start becoming level 3. It's very important to look for these lymph nodes at different levels. And a particularly important location is the level 2 position between the pec major and minor, called the rotor space, because if these lymph nodes are not addressed, they will lead to treatment failure locally. Also important are the internal mammary lymph nodes. So here is an example of an internally mammary lymph node recurrence in a woman who had a mastectomy. So this is how it causes a treatment failure, and this needs to be addressed then by thoracic surgeons because of the involvement of the chest wall. So MRI helps us in looking for the different lymph nodes very nicely, and it's very useful modality. So just a quick overview of breast cancer treatment and how it has evolved since the 1970s, where we moved away from performing very disfiguring kind of surgeries to more breast conservation type of surgeries. And the two landmark studies really were the NSABP of 04 and 06 trials, which basically proved that breast conservation with adjuvant radiation is a reasonably safe option for the management of stage 1 and stage 2 breast cancer. So basically, it meant that these women no longer need to have a radical mastectomy. And if you look at these slightly complex graphs, but just follow it, it's really simple. So the solid line is the radical mastectomy, and the small dotted line is mastectomy with irradiation. So if you look at women who are node negative, women who have mastectomy versus those women who have mastectomy with irradiation, the graphs pretty much follow the same kind of curve. In fact, those women with mastectomy with radiation show a lower amount of incidence of local recurrence. And if you look at the distant recurrence, again, the performance is fairly similar. If you look at women with positive lymph nodes, again, you can see that these two graphs are pretty much close and following the same curvature, which basically means that if you had a total radical mastectomy and if you had a less radical mastectomy with radiation, then the outcome is going to be the same. So why have a radical mastectomy? The second study, the 06 study, basically again showed the importance of radiation, adjuvant radiation. And here you can see that they looked at three different aspects: disease-free survival, distant disease-free survival, and overall survival. And they basically showed the same thing, that women who have lumpectomy and irradiation versus mastectomy, there is really no difference in the outcomes. And in fact, they showed that if there was added radiation, it was improved, the distant disease survival, and all three parameters showed a great improvement. So it just proved again that breast conservation treatment with radiation helps. And if you look at the more recent data from the American Cancer Society, we can now see that majority of the stage 1 and stage 2 breast cancer diagnosed women will choose or will benefit from breast conservation surgery with radiation. So this is the graph which shows us that this is certainly like an established way of managing stage 1 and stage 2 cancers. So the success of breast conservation treatment actually depends on proper preoperative staging, and that's where MRI comes in. So if you prove that this is a stage 1, stage 2 disease, there is no other involvement of any other structures, there's no DCIS, and it's very easy to perform these surgeries. And here is a very nice example of a woman who underwent breast conservation surgery with a beautiful scar and a nicely shaped breast, and it allows us to conserve the breast. It is important to assess the size of the tumor to the breast. If the tumor is small, but if the breast is also small, then sometimes breast conservation may be difficult because you will not get a good cosmetic outcome. So you need to assess the size of the tumor and the size of the breast to match it up. We also need to look if the patient needs adjuvant chemotherapy or radiation, because this also helps reducing the long-term recurrence rates and local recurrence rates. So there are many different aspects which help breast conservation treatment to be more successful, and of course, axillary assessment. What are the contraindications? Contraindications for breast conservation is recurrence, multicentric disease, T3 tumor, pregnancy, extensive disease, and prior history of radiation, because then these women cannot really get more radiation after breast conservation. So that is one of the contraindications of breast conservation treatment. Here is an example of a lactating young woman, very dense breast, because obviously she's lactating, presents with a palpable finding. You can see a vague, kind of partially obscured mass with some speculations, definitely a Byrad's 5 lesion on ultrasound. And here is her MRI. There's tumor everywhere. There are multiple small, lesions. There are masses involving the entire breast. So this is multicentric disease. And just based on these two images, you really can't offer her appropriate management, because then you are going to leave back so many other enhancing speculated cancer foci. So this is the importance of staging, is to know how much tumor there is, so that proper selection for breast conservation can be performed. So now that this is an established way of performing, surgery with adjuvant radiation, it is an established standard of care. And the SEER data revealed that the rates of mastectomy declined significantly for early stage breast cancer between 1980 to the mid 2000s. But after that, it was seen that from approximately 2005 to 2008 and so on, there was a gradual increase again in the rates of mastectomy for early stage cancer. And there are multiple publications. Here's one from 2015 from JAMA, which again showed that in the US, there was increase in trends for mastectomy for early stage breast cancer. And more data was coming in. And again, they showed that the rates of mastectomy from 1998 to 2011 almost went from 5.4% to a staggering 29%. So a huge increase in not only just unilateral mastectomies, but bilateral mastectomies for unilateral early stage disease. And then there was also a concurrent increase in the reconstructive procedures in this particular group of women from 36 to 57%. So it indicates that there was something happening why this increase in the rate of mastectomy was noted. And if you look at the more recent rates, they're even higher than what was previously documented in the SEER population and regional centers. So here's another paper that was published in 2009, where the rate of mastectomy surpassed that of lumpectomy for early stage cancer, despite of counseling. So what is the explanation? Is it because of fear of cancer recurrence, perceived survival benefit? These are all patient-related factors. Greater patient autonomy of deciding what she wants, how she wants to have her breast treated. And one of the important reasons described was increasing use of preoperative breast MRI. Now, this is not what we want to hear. Neoadjuvant treatment, obviously, for locally advanced breast cancer, and the fact that neoadjuvant treatment is now being offered to even smaller sized cancers based on their receptor status, and availability of cosmetically favorable reconstructive techniques such as skin sparing, nipple sparing. So people were just choosing to have a mastectomy and immediate reconstruction. So these were the reasons why, which were the confounding factors why the rates of mastectomy were increasing. So we're going to talk about just the preoperative breast MRI. And we know that breast MRI is very, very sensitive, close to 94 to 99%. And it was hoped that using breast MRI for breast cancer staging would translate into improved surgical treatment and improved local control. So this is what you would expect would happen. So there are some publications which show that there is increased utilization of breast MRI across the world, particularly in staging for breast cancer. It is being frequently used in young women. It has been broadly recommended for staging in some guidelines without any restrictions. And of course, there are some specific criteria such as young age, high risk patients, invasive lobular disease, dense breast tissue, and so on, where MRI is definitely beneficial. So then there was a lot of criticism because MRI was detecting additional disease that is not seen on conventional imaging, and that was leading to more harm than benefit. So some critics of uh, breast MRI were accusing MRI that it is like having one step forward and moving two steps back. So MRI was picking up the small additional foci of disease, which we know can be addressed on radiation. So there was a huge controversy about where and how and should preoperative MRI even be used. So what are the key questions as radiologists? What do we want to know that will help us understand whether or not breast MRI should be offered? So the first question is, what is happening to the surgical treatment? How many women are getting breast conservation or versus extensive surgery? What are the mastectomy rates? What are the re-excision rates if the patient has MR? And what is the long-term benefit? Is there mortality benefit? Is there benefit in local control? Is there a benefit in distant recurrence? And then, of course, cost, availability, intervention, second look ultrasound facilities, MR biopsies, and treatment delay. So these are the key points that we should address before we can decide whether we should be doing preoperative breast MRI or not. So let's look at surgical treatment. So breast conservation versus extensive surgery, mastectomies, false positives, and overtreatment. There's a huge meta-analysis that was published by Nehmet Husami et al. In 2017, wherein they looked at multiple studies systematically to derive conclusions about the body of the research. And their goal was to show the association of preoperative MRI with surgical treatment in women with newly diagnosed invasive breast cancer. So there were 19 studies that they pooled, and there were over 85,000 subjects. And what they showed, their endpoints were how many women received ipsilateral mastectomy, and then there were other endpoints such as re-excision, positive margins, reoperation, and contralateral prophylactic mastectomy. And what they showed is there was no evidence that preoperative MRI improves surgical outcomes. MRI was associated with increased odds of receiving mastectomy, and increased mastectomy was not a function of older studies. Like we always say that, oh, in the past there was no MRI intervention and therefore women had more mastectomies. Now we have the capability of doing MR biopsy and directing the surgeons more accurately. So their study didn't confirm that. And they also showed that there was a large number of false positives. So additional foci of disease was detected in about 16% of women. And those 16% additional foci that was seen, 66% of them were malignant. So one third, almost one third to one fourth of them were false positives. So for every 1.9 true positive, you had one false positive. That's pretty high. And that all adds to delays, anxiety, and most importantly, also cost. So it is important to have expertise in breast MRI interpretation as well as biopsy capabilities, because otherwise you're going to be dealing with a lot of false positives, which may actually affect management. Overtreatment, there's always talk about overtreatment in breast imaging. And what they showed is the MRI, using MRI in preoperative staging led to a change in management, 15 to 27% in the terms that about 11% women had extensive surgery. Some women who were eligible for breast conservation treatment decided to just go ahead with mastectomy because of the MRI findings, and about 5 to 6% had more extensive surgery for false positive findings. So there was a lot of false positives that led to overtreatment. Here is an example of a woman who had a biopsy proven invasive ductal carcinoma, and she ended up having an MRI, which showed an additional lesion. And although this was a DCS, she just decided to go ahead and have a mastectomy. So women do tend to choose mastectomy when you find additional, findings. In this is another example in the left breast. There was an invasive ductal cancer. Another lesion was seen in the contralateral breast. She had multiple biopsies for that. And again, so this is a false positive that we sometimes see in MR, which can lead to a treatment delay or over treatment. So we need to be very careful. So what about re-excision? Is using MRI leading to re-excision rates being lower, less incidence of getting tumor at margins? Does MRI help with that? And this is the most commonly uh, quoted trial, the COMIS trial, which had a lot of problems with it, but nevertheless, it is quoted, and they showed that MRI is not necessary in patients. Like, it does not contribute to reduced repeat operation rates, right? So this was performed in UK, and there was a lot of controversy about this study, but nevertheless, they showed that it's basically useless to reduce the re-excision rate. So MRI did not impact re-excision rate. However, data that was looked at our facility, where the surgeons are very specialized, we did show that there was some improvement in the re-excision rates. This was how their study was set up, and they showed it was randomized, but they showed that it did not help. And then this study, which was published a little bit later, showed that there was actually improvement of margins. After using MRI, they had about 1,400 patients, and then they, kind of put them in two different arms. And just to briefly show you, this was the arm that used MRI. And out of the women in whom breast conservation was performed, margins were involved in 5.6 versus 14.6 in those that didn't have MRI. And if you follow these ones, if you go ahead, they had surgery, they had reoperation, and out of them, 9 had residual cancer, as opposed to here, 22 had residual cancer. So it did show some degree of improvement in the re-excision rates. So there's variable literature on that. What about long-term benefit? There is there a mortality benefit? Is there in-breast recurrence, lowering of in-breast recurrence, or is there distant recurrence? Again, there was multiple studies that looked at this, and basically there was no difference. This was a breast cancer surveillance consortium. There were like multiple patients engaged in this, and basically they showed that it is not associated with mortality benefit, does not improve surgical outcomes, or diminish breast cancer specific mortality. And so its role, like they said, was more qualitative in providing information to women and the referring physicians, surgeons, regarding the presence or absence of additional breast disease. And then they can choose what they would like to have. So patient-centered outcomes are more important to examine regarding the use of preoperative breast MRI, right? So this was what they proved. And then again, there's really no randomized data available to look at whether MRI reduces local recurrence or distant recurrence. But this is very, very patient-centric. Is this individualized management is necessary for utilization of breast MRI. This is the same. They're showing that with or without MR, there's really no difference at all in the distant recurrence. Other considerations, we already talked about: anxiety, treatment delays, MRI intervention, cost, and we know that it leads to delays. Scheduling is a nightmare, especially in young women. Patients are very anxious, especially when we find additional findings. We have to reschedule them for MR biopsies, second look ultrasounds. More workup is necessary, and it often leads to a lot of patient anxiety. MRI intervention is very important. It is also very expensive to perform MR biopsies, but any finding that will change the management needs to have some kind of pathological diagnosis. So it's very important to have this facility available if at all you are providing preoperative breast MRI. And of course, there is a cost to it. So we tried to address all these questions like what does MR preoperative breast MRI really offer? So we saw that really it can lead to extensive surgery. Patients are choosing to have more extensive surgery following MR. That's been documented. Part of it is also because they would like to have immediate reconstruction with nipple sparing and so on. We're going to talk about that in another talk. So re-excision rates really it's variable. It is very difficult to have a randomized study with a modality such as MRI, which is very impactful. So there is mixed data available there, with some surgeons believing that it does not affect re-excision, and some studies showing that there may be some improvement in the re-excision rates. Mortality benefit, distant recurrence. This is very difficult to prove because we don't have a long-standing data available for MRI like we have for mammography. So really, because we cannot really randomize right now, it would be very hard to prove that. And of course, the costs and treatment delays. So yes, it is a modality of clinical impact. It shows us amazing kind of information, which does impact the patient management. But we have to be very careful in whom we are offering preoperative MRI in order to prevent overdiagnosis, overtreatment of these women. And these are the few indications where preoperative MRI is really useful, such as an invasive lobular cancer, especially used in the setting of newly diagnosed invasive lobular cancer, high-risk women with new diagnosis of breast cancer. So these are gene mutation carriers, other mutations, mantle radiation, women with lifetime risk, more than 25%, women with neurofibromatosis 1 syndromes. And so there's a group of these high-risk women, like Ashkenazi Jewish individuals, and so on. Then the other indication also is dense breast tissue with new diagnosis of breast cancer. I showed you a few cases where there is dense breast tissue and you really cannot see the true extent of disease, and MRI is very useful in this, particularly in young women, like I showed you the case with the lactating women. Non-calcified DCIS is very important. If you get a high-grade DCIS diagnosed on a biopsy, let's say ultrasound biopsy, and there are no associated calcifications, there's dense breast tissue, definitely MRI will be useful to look for associated invasive disease and the true extent of non-calcified DCIS. This is one of the quite of important indication that you may offer a preoperative staging MRI. And of course, neoadjuvant setting, you need to perform MRI pre and post neoadjuvant to look for the response of the tumor to the treatment that has been given. This is one of the indications of preoperative MRI and is liberally used. So just to summarize, we need to provide a balanced view towards MR utilization. It has to be personalized to the setting in which the patient is presenting. What is her tumor biology, her risk status, breast density. So there's a lot of considerations. The use of breast MRI should be evidence-based, and we discussed a lot of it right now. It was a brief overview, but we went through all the different aspects of evidence. And of course, the expertise of the surgeon and radiologist are very critical. In the hands of an expert surgeon and an expert radiologist, the outcome is always going to be excellent. So that's very important. There's a great deal of patient education that is required to counsel women about the MRI findings, what it means, so that they make a proper decision with respect to their management. And of course, patient preference is very important. So this was just a brief overview of what is going on with a preoperative breast MRI. And I hope this really helps you to guide your practice and make appropriate choices for your own patients. And so we will take questions as soon as the talk is finished. Thank you.
Dr. Sahar, I think we will have all questions by the end of the session, by the end of the 3 talks. You may now, Dr. Sahar, can you unmute yourself, Professor Sahar?
Thank you, Miret. Thank you, Miret. First of all, I would like to express my gratitude to the organizing committee of the BGICC, presented by Dr. Rasha Kamel, Dr. Mirat Al-Madawi, and Dr. Iman Awis. And I welcome my guest speaker, the guest speaker of the session, Professor Kulkarni. Actually, she's a recipient of several teaching awards, including the prestigious Whiteman Barry's Academy Individual Postgraduate Teaching Award 2014-2015, and the Outstanding Contribution to Cancer Education Award, awarded by the Princess Margaret Cancer Education Program 2017, Princess Margaret Cancer Center, Toronto. The second lecture for Professor Kulkarni will be about the breast cancer surveillance. Will you proceed, Dr. Kulkarni?
Hello, everybody. I will be talking about breast cancer surveillance. And once again, I want to thank the organizers for having me here, talking at the 13th BGICC conference in Egypt. And I'm happy to be presenting all the way from Canada. So let's start talking about breast cancer surveillance. And I'm just going to pull up my screen here. And okay, here it is. So we will be talking about how to manage women once they've been treated for breast cancer. How do we keep monitoring them, and what would be the ideal way to do it? I have no disclosures at all. So the learning objectives of today's talks are, we're going to briefly touch upon the evolution of surgical management of breast cancer, which is very important to understand, and we did discuss it earlier today. We will also talk about local regional recurrence, impact on surveillance, and we'll look at a little bit of evidence and what the current guidelines and recommendations are for surveillance, and what are the benefits of surveillance in a high-risk population, and some newer things which are becoming mainstream, such as nipple-sparing mastectomies, skin-sparing mastectomies. What do we do with them? And then we'll look at some challenges associated with imaging of reconstructed breasts. So let's move on. So this is a very old picture which basically shows how disfiguring the treatment of breast cancer was. So even for early stage breast cancer, women were getting very disfiguring Halsted's mastectomy, where the whole breast and the tissue was removed. The surgical management of breast cancer has changed following these large longitudinal studies, the NSABP trial 04 and 06. And basically what they showed is breast conservation with adjuvant radiation is equally useful in terms of long-term survival, local recurrence, and in all different parameters for the management of stage 1 and stage 2 breast cancer. And this really revolutionized how breast cancer was being treated to a more minimally invasive treatment, which was more acceptable to women, and they could keep their native breast. This is a nice example of a breast conservation surgery, and the benefit that was shown is it's good enough for local control, for survival, disease-free survival, and also distant metastasis. The success of breast conservation treatment depends on proper preoperative staging, absence of associated DCS, clear margins, the ratio of the breast cancer to the size of the breast, and of course, adjuvant and neoadjuvant treatments and radiation, and axillary assessment. So all these things put together really allow breast conservation treatment to be successful. What are the contraindications? We looked at this before: recurrence, multicentric disease, large tumor size, small breast size, pregnancy, and extensive locally advanced disease, and of course, history of prior radiation to the breast, which precludes further radiation. These are the type of cases where you will not offer breast conservation because it's never going to be successful. So it's very important to understand patient selection is very important for success of any surgical technique for that matter. So what are the scenarios that we will have once a person is treated for breast cancer? So there are multiple scenarios in terms of management. The first scenario, of course, we've been talking about it, is breast conservation treatment. The second one is unilateral versus bilateral mastectomy. Women may choose to have either of them based on what their preference is. Patients after having surgery may go on to reconstruction. This could be immediate reconstruction, delayed reconstruction. The reconstruction can be of different types. It could be implant reconstruction, or it could be autologous reconstruction. So there are so many options. And then women may also have augmentation or reduction of the contralateral breast to for the sake of symmetry and making the breast look equal and symmetrical. So there are a whole number of things that a woman can choose, and she can be offered for the management of breast cancer. So breast cancer survivors, what are the risk factors? They are at an increased risk for developing a second breast cancer now than an average risk population, general population. Now, the second breast cancer could be in the form of a local recurrence. It could be in the form of a completely different type of cancer involving the same breast. There could be a higher incidence of developing a breast cancer in the contralateral breast. And of course, there's always distant metastasis if there is a local recurrence. Imaging surveillance has proven that it does improve survival and it does improve quality of life. But what we want to discuss is what type of imaging surveillance should be offered and how we do it. Recurrence is one of the most dreaded things for any patient, any woman who undergoes treatment. Every time she comes for a mammogram, it's a huge deal because they always feel that we are going to find something. Here is an example of a woman who's had prior surgery in the kind of central, little bit medial left breast, and you can see that there is a newly developing spiculated mass, very subtle, but nevertheless, it was a new finding. Not so clearly identified with spot compression use, but nevertheless, it was real. And here it is. You can see on ultrasound, small area, spiculated, shows a little bit of a halo, and there it was seen clearly following a needle localization. A 25 gauge needle was placed through the mass, and a mammogram was repaired. So this is an example of recurrence, and it is close to the surgical bed. And definitely this is seen very nicely now. The recurrence can also be quite large, and especially when it is posteriorly located, inferior, and it may not be detected till it's like very large. As another example of a woman who has a lumpectomy, you can see the surgical clips in the upper outer quadrant of the right breast, huge mass in the inferior quadrant. And here it is on ultrasound, very close to the muscles, sitting right on the abdominal wall in the inframammary crease, very difficult to detect sometimes on mammography. So this is another example of recurrence. Here's a nice example, very close to the surgical bed, a new dense mass, which on ultrasound is located quite superficially. And this is elastography. It shows that this mass is quite stiff, which indicates that it is likely going to be malignant. So here's another example of recurrence. What about women who have a mastectomy with no reconstruction? What should we do with them? So women who have conventional mastectomy for invasive disease, the likelihood of local recurrence is 2.3 to 10%. And of course, this depends on the age of the patient, the stage of the disease, a response to treatment, and whether she had adjuvant radiation or not. The local recurrence rate for DCIS is very low. So any woman with DCIS who has a mastectomy, the likelihood of recurrence is absolutely very, very low. So it's quite, in that sense, completely therapeutic. So there is some risk involved. When the patient has a mastectomy, there may be some incidence of recurrence on the chest wall. But for these women, as there is no breast tissue left, obviously we cannot perform a mammography. It will be completely useless and you won't be able to perform. Even assessment of the axilla with the mammogram has not been found to be useful. And in these women, palpation is the best technique because any tiny cancer that develops is going to be immediately palpable to the patient. And traditionally, surveillance of women who've had mastectomy with no further reconstruction is palpation and clinical examination. Of course, we will continue to screen the contralateral breast, but for the side of the mastectomy, no further imaging is offered. Sometimes after the mastectomy, the patients may have like a loose flap left over, and some of them actually can be imaged on mammography, but it's rather difficult. But nevertheless, clinical exam is the first line of surveillance technique for a post mastectomy case. And here is an example of a woman who had a mastectomy, and you can see her mastectomy scar is like healed really nicely, but very shortly after her surgery, she developed these multiple red kind of papules on the breast. And you can see that there's like a blush of redness here as well. And obviously, this was not a good sign. She did undergo a punch biopsy, and it led to a diagnosis of recurrence. So it was not a good outcome for this patient, and it can like come back quite fast if it is a biologically very aggressive tumor. So if we just look at the brief NCCN guidelines, this is just a snapshot, and basically I would like to draw your attention to imaging is how would you follow up a woman who has invasive breast cancer, treatment for invasive breast cancer. Surveillance follow-up is mammography every year. So every 12 months, mammography is suggested. There is no need of routine imaging of a reconstructed breast. So there is clear indication, clear guidelines that a reconstructed breast may not need any further imaging. There is no need to screen for metastasis in the absence of clinical signs and symptoms. So this is a very nice single slide kind of information about how to follow it on how to follow women on general exam, genetic screening, and of course we want to talk about imaging. So annual mammography is the way to follow these women who have some breast tissue left on the ipsilateral side and obviously on the other side. This is the ASCO guideline, which kind of resonates the same NCCN guidelines, and they make this very important observation that there should be individualized clinical follow-up. So it's again, personalized care is very important. Each patient is unique. Their needs are unique and they should be catered to. So it's very important to spend time to figure out what each person requires, especially after they've been treated for breast cancer. Are they high risk? Do they have dense breast tissue? What is their risk factor? Was their lifetime risk? There's so many considerations. And they again say that screening for the breast for local recurrence or a new primary should be performed by annual mammography. Okay, for the intact breast, and those who have had lumpectomies, annual mammography. So everybody says the same things. It is important to understand that routine use of MRI is not to be offered for women who have had a lumpectomy or a mastectomy unless the patient meets high risk criteria. So there should be high risk criteria which are satisfied before you can start offering MRI to women for surveillance. There is some evidence in the literature that if you screen women with mastectomies or women with lumpectomy and dense breast tissue, MRI may actually be beneficial. But again, like I said, personalized medicine is necessary. So then we're going to talk about breast reconstruction. Women can have breast reconstruction for many different reasons: cosmetic augmentation, reduction, nanoplasty, adjustment of the nipple, and so many different, cosmetic procedures. risk reduction surgery in high-risk women, women who are very high risk for BRCA gene carriers, other genetic mutations, may choose to have risk reduction mastectomies in after they finished having children, and or they may do fertility preservation. So these are the women who will have mastectomies and they will be followed by reconstruction. But today we're going to focus on breast reconstruction that happens as a sequelae of breast cancer treatment. So we're just going to focus on that particular group. So there is no consensus about the optimal method of detecting local recurrence in a reconstructed breast. Practices vary across institutions, and like I showed you the guidelines, it clearly mentioned that there's no need to follow a breast that has been reconstructed following a mastectomy. And so there is no randomized control trial that gives any information. So it's really very individual. Some women prefer to have their reconstructed breasts followed with mammography. Others specifically don't want anybody touching that breast. So it varies from surgeons to surgeons, referring physicians, as well as individual patient preferences. So after a post breast cancer mastectomy, what are the different options for reconstruction? So you could just have an implant reconstruction, or you could have autologous reconstruction, or you can have a combination where there is autologous as well as a little bit of implant to augment the size of the breast. In autologous reconstruction, there are many different types. TRAMs, DIEPs, latissimus dorsi, there are so many other types of autologous reconstruction. The commonest one, at least at our facility, which is subspecialized in DIEP. So we see a lot of DIEP reconstructions at our institute. So these are the different options that patients can have. Let's look at implant reconstruction. So as we know, implants can be retropectoral or implants can be prepectoral, but in women with reconstruction for mastectomy, they're always retropectoral because there's no breast tissue to hold the implant. There's no breast pocket to hold the implant. So they're usually placed behind the pectoralis muscle. And what that does is it pushes the pectoralis muscle, and whatever residual tissue is left on top with the skin, a little bit of subcutaneous tissue, and it gets pushed out by the implant so that if any finding, if any mass develops, it would immediately be palpable. So it's almost like pushing the mass out. And so for these women, really no imaging surveillance is required. A clinical exam, a routine clinical exam would be what is required for these women. So women with implant reconstruction following mastectomy do not require any further mammographic imaging surveillance. Here's a nice example of an implant reconstruction, fairly large size implant in this woman. And you can see that there's hardly any tissue left behind. In fact, even the pectoralis gets pushed anteriorly and is really stretched thin here. So if anything were to develop, you would immediately palpate it. So this is a nice silicone implant which is intact. The other breast looks very good. One of the considerations when we talk about implant reconstruction nowadays is the textured implants. The textured implants are known to be associated with a slightly higher risk of developing anaplastic B-cell lymphoma. There's a lot of talk about this in the recent days. And here is a very nice example of an implant in the left breast, which presented with a sudden onset swelling. There's a swelling of the left breast, and there was some tissue, hypoechoic tissue around the implant. Obviously, MRI is the best modality to assess implants and implant complications. And here's a post-contrast implant protocol that was performed, and you can see that all around the capsule there is irregular enhancement, and this was very abnormal, and this was proven to be anaplastic B-cell lymphoma, which was there in the capsule. So obviously this was removed. So this is obviously not a breast cancer related patient, but I'm just showing you these kind of implant complications can also occur in women who have augmentation with textured implants. Let's look at autologous reconstruction. And obviously, I didn't show different examples of implant rupture because That's like so common. I don't need to show that here. We're not talking about implant assessment per se. So autologous reconstruction, in this, the benefit is that the patient has natural tissue which is forming the breast. The breast mound is placed above the pectoralis. So remember the difference. The implant is always placed behind the pectoralis, but a reconstructed autologous reconstruction is anterior to the pectoralis. And usually the pectoralis posterior fascia over the pectoralis is stripped off. So that is the one place where you may have some TDLUs left behind. So it's usually stripped off. And so the posterior chest margin is like right on the chest wall. It's like right on the pec muscle. And therefore, if there are any deep recurrences, you will not be able to feel them. And so this is one of the considerations in women who get autologous reconstruction for a bad size of cancer, like locally advanced cancer or very biologically aggressive cancer. And so these women are naturally susceptible to higher local recurrence. And if such a woman receives an autologous reconstruction, the deep recurrences will not be palpable. So there is some discussion that maybe in a subset of these women, some kind of imaging can be offered. Majority of the recurrences will occur in along the skin surface, particularly in the DIEP scenario. So here is an example of a nice DIEP reconstruction, normal breast, a native breast, and here is a reconstructed breast, completely fatty tissue that is brought up from the anterior abdominal wall, and this is the site of the anastomosis of the vessels, and here is a black line, and so this is called the transition zone, and this is where you will get majority of your recurrences. So that's seen in DIEP sequences, a DIEP kind of thing. And here is an example of a recurrence. As I said, there is this line which represents the denuded epithelium, and that is an interface between the abdominal fat and the native subcutaneous fat. So there's a denuded kind of epithelial layer, and that is where you may have an occasional TDLU left behind, and that is the culprit TDLU will develop a breast cancer. This is a nice example to show you a classic cancer associated with a DIEP reconstruction. Other complications such as fat necrosis, very common, very classic on mammography, very classic on MRI. And here's a big area of fat necrosis. You can see the fat, and they can enhance. Fat necrosis can look like cancer on any imaging modality. It can look suspicious on mammo, on ultrasound, on MRI, elastography, you name it. They can really mimic breast cancer. But when it looks like this, it's very classic. It's fat necrosis. Here is an example of a woman who had a breast cancer. She obviously had a DIEP done, and the DIEP presented with a large area of fat necrosis. It's quite common, but it's again very classic appearance on MRI. It shows fat in the center, and the enhancement is all around. This is a very classic appearance of fat necrosis. This is a paper that was, talks about, it's an old one coming from Sloan Kettering, and they talked about incidence and of recurrences in these women with TRAM reconstruction. We're talking about TRAM now. And what they found is that local patients with a local recurrence in these women can present as pain or discomfort, because all these recurrences are situated on the chest wall. They all happen posteriorly, as opposed to DIEPs, which happen superficially. With tram flap, the recurrences are usually very posterior, and they have a very bad prognosis because they may be detected quite late. Okay, they found a local recurrence rate of 3.8%, and the mean follow-up was approximately 5 years. So they can occur on the chest wall, which are difficult to detect, and sometimes in the skin flap, which are obviously quite easy to detect. They present as palpable masses, scar changes, skin changes just like you would see in a DF. They further describe that early detection of isolated local recurrence on the chest wall um, did not really show any further actual uh, survival rates after 10 years. So basically, there was no benefit demonstrated in terms of long-term survival of these disease-free survival. And therefore, the conclusion was that addition of imaging um, for women with reconstruction with TRAM may not, there's no evidence that it alters treatment course or outcome. So basically, both for DEP and for TRAM, there's not enough evidence that screening, surveillance of every single reconstructed breast every single year may not offer any major benefit. So here's an example of a woman 2004 2007, 3 years she decided she didn't want her tram to be evaluated. At 2007 it looked a little bit different. There was more tissue posteriorly which looked abnormal. Obviously she had a tram recurrence, and you can see how when it is deep it's not palpable and it involves the muscle directly, so the prognosis is worse in terms of management and everything. And she also incidentally was detected to have a contralateral cancer. Another deep recurrence here in the region of the axilla almost, and here it is, a big cancer here. So it can recur in the level of the axilla as well. So reconstructed breast looks fine, but there is recurrence in the axilla. I just briefly want to discuss this before we end. Is skin sparing and nipple sparing mastectomies are becoming more talked about. There is a drive to perform these, particularly in women who have prophylactic risk reduction. So even women with early breast cancer may choose to have uh, skin sparing mastectomies or nipple sparing mastectomies, and they may choose to have immediate or delayed reconstruction. So they would have a skin sparing mastectomy. They may have a temporary uh, um, take, temporarily have some implant placed, and then they may come back later for a delayed reconstruction, which could be autologous or not. So the benefit of skin sparing mastectomy is preservation of the 3D structure of the breast. So the breast after reconstruction looks completely normal because the original kind of capsule, the original shape and the pocket of the breast is preserved. And it's a more psychologically acceptable, particularly in young women who are having prophylactic mastectomies. This is a classic example. This is a woman who presented with a triple negative high grade tumor, received neoadjuvant treatment, complete radiological response was seen following neoadjuvant treatment. So she clearly benefited from her neoadjuvant treatment, and such women can undergo skin sparing mastectomies for high risk disease and still have a very, very good outcome. Um, if you look at the histological review of the skin flap, it's very interesting. The skin flap in 59% showed residual breast tissue. So this is very interesting. So what this is saying is, despite of having a skin sparing mastectomy, you may still have some residual tissue left behind. And in this particular series where they looked at glandular tissue after skin sparing mastectomies, 9.5 showed residual carcinoma. So if your skin flap is thick more than 5 millimeters, there is likelihood of residual breast tissue. And so the technique is very important. Just having an external skin sparing mastectomy doesn't really mean anything, but the skin flap has to be very, very thin, less than 5 millimeters. So you basically have to just shave off the breast from under the skin. And here is an example of a modified radical mastectomy where the whole breast is removed and the skin and the areola and the nipple is removed. This is an example of a skin sparing mastectomy where you can see that the skin is preserved here, but the nipple and areola is removed. And you can see that it's very close And when you do a nipple sparing mastectomy, you have the skin and the nipple areola preserved, and there is some tissue going to be left behind. And in a high risk woman, one TDLU is enough to cause recurrence. So basically, the technique of these surgical techniques are very important. And if, like I said, if the skin thickness is more than 5 millimeters, there's definitely going to be some residual tissue which can grow if the patient gets pregnant, and so on and so forth. So cadaveric tissues again show that there is residual tissue left behind. And so maybe some of these nipple sparing mastectomy women may benefit from surveillance, especially if they're very high risk. If they have a 60 to 80% likelihood of developing cancer, as is seen sometimes with the BRCA gene mutation carriers, they may benefit from routine surveillance, right? So again, patient eligibility, you have to be very careful in who you want to offer these. So it's important. We have seen some women who, after their mastectomies, start developing axillary breast tissue or breast tissue somewhere along the just in the subcutaneous regions, and it's pretty astounding how the breast tissue starts to grow after removing the entire tissue. So these women actually need some kind of surveillance, but there's not enough data. This is a nice nipple sparing mastectomy, a sagittal view. And so that was about nipple sparing mastectomies and skin sparing mastectomies. What about ipsilateral cancer recurrence? The ipsilateral cancer recurrence is similar in skin sparing mastectomies versus traditional mastectomy. So there's no difference. There is some publications which describe that, and therefore bilateral mastectomies in a BRCA gene carrier does confer on 95% risk reduction, just like a traditional mastectomy versus a skin sparing. The local recurrence, again, for DCIs is very, very low, right? Any additional tissue that is left behind would confer 1 to 2% risk. And so that is really approaching a BIRATS 3 kind of likelihood of developing cancer. So that is the projection that they talk about. Some small amount of tissue is left behind. This is another meta-analysis which basically said that there's no difference in the local recurrence in skin sparing versus nipple sparing. So we've looked at all three: traditional mastectomy versus skin sparing versus nipple sparing. So they're showing that there's no significant difference. This is ipsilateral breast cancer after DF. So in this, they said that the ipsilateral recurrence has a higher incidence than the contralateral breast, indicating that maybe surveillance should be performed even for the contralateral breast. So there's like all kinds of data, no clear direction towards what should be done. Definitely, there's no large randomized controlled trial to give us a clear indication what we should be doing for these women. And this really nicely shows that the likelihood of the ipsilateral breast, the side that had a cancer, the likelihood of developing recurrence is seen in the first 5 years. And after 5 years are crossed, if at all a new cancer is going to develop, it's likely going to develop in the contralateral side. So people also talk about offering additional surveillance to the affected breast a few years right after their mastectomies. So there's data about that as well. So guiding principles are to be considered. Age is important. Clinical disease, is it T4? What was the nodal status? Was the lymph node positive? What was the response to neoadjuvant treatment? Was the tumor close to the nipple? This is very important. The surgeons always ask us how close is the tumor with respect to the nipple, because that's what determines whether they can perform a nipple sparing or not. And if the nipple is close to the mass, and the patient absolutely insists on having a nipple sparing mastectomy, these are high risk women, right? Unfavorable tumor characteristics, no radiation, patient has declined radiation or cannot have radiation. So these are the few things that we have to consider when we talk about offering surveillance to a reconstructed breast. So we saw all kinds of evidence, but it all boils down to, again, personalized a plan for every individual patient. Anyone who is moderate to high risk would would benefit from receiving some surveillance. We know that radiation is useful, and women who don't have radiation or those who decline radiation will be at a higher risk of developing recurrence. Gene profiling is important. Oncotype DX will help us to uh, know what would be the recurrence risk locally after mastectomy. So if you get a high score, high recurrence score, then there can be a high likelihood of local recurrence. So again, this will help us to kind of triage which patients are high risk and allows us to stratify which patients should be guided to get ongoing surveillance. So there's lots of considerations here. It is definitely not one hat fits all heads. So these are, again, I've just listed the different considerations and who should receive ongoing surveillance for a reconstructed breast. What is important to, again, just understand is if the local recurrence risk is higher than 2%, those are classified as moderate to high risk women. And those are the women who may benefit from some kind of surveillance with mammography or MRI. But there is no clear randomized controlled trial which will tell you to go one way or the other. And it all depends on how your individual practice works. So to conclude, this is an era of personalized care. Every talk that I give, I'm continuously trying to explain that you cannot have one approach for everybody. Mammography is the first line of surveillance when there is native tissue left, that there is a normal breast, contralateral breast, as well as breast conservation. So mammography is the first line of surveillance that has been clearly indicated by all the societies and guidelines. Annual surveillance is suggested for breast conservation treatment. We already saw that. There is lack of robust evidence for routine surveillance of reconstructed breast. We discussed that at length. Individual risk assessment may give some guidance as to who should be offered surveillance, particularly in a high risk status with nipple sparing, skin sparing, mastectomies. Although MRI is cost prohibitive, if at all you want to offer one test for breast, a reconstructed breast, it is by far the most useful modality and also helps us in looking at the implant and the deeper tissues and the complications. So I want to thank you for attending this talk, and I will be happy.
Okay, so Dr. Aisha, would you like to announce about the third talk?
The last talk for Professor Kulkarni is the imaging of lobular carcinoma. Please, Professor, can you start?
Hello, everybody. As we move along, I will be talking now about invasive lobular carcinoma. And again, it's a great pleasure to be here talking at this conference. And I hope that everybody enjoys this talk. So let me pull up my slides here again. And here we go. So invasive lobular carcinoma is one of my favorite topics to talk about because it's such an interesting pathology to detect and manage and evaluate on breast imaging modalities. I have no disclosures at all. So our learning objectives for this talk is just talk briefly about epidemiology. There's some pathological considerations. We need to see how it looks on different modalities, and just focus a little bit more on understanding the role of MRI in the assessment of invasive lobular carcinoma, discuss briefly the management, and I would definitely like to touch briefly upon lobular neoplasia and its implications. So invasive lobular carcinoma, there are many different types as per the WHO classification. There's a classic type, solid type, alveolar type, and the tubular lobular type. And we also like to talk about the pleomorphic invasive lobular carcinoma, which is the most aggressive form of ILC that we see. It is the second most common breast cancer, obviously following the invasive ductal carcinoma, and it accounts for about 5 to 15% of all breast cancers that you would see. And there has been a trend where it's been noticed that the incidence has increased in the last couple of decades, and it's been said that it may be due to the use of HRT. And obviously, therefore, it presents mostly in older women. And it tends to be multifocal, it can be multicentric, sometimes it can be bilateral. So that's how it typically would present. Invasive lobular carcinoma has a very unique pathology. It grows very diffusely and does not elicit any desmoplastic response. So the desmoplastic response is what makes the cancer spiculated and irregular margins, but ILC does not show any desmoplasia, and therefore it can be very difficult to detect on breast imaging, particularly on mammography. It is difficult to detect on physical exam also, as is with imaging. However, if you match the stages, the outcome is quite favorable. It's just that it may be detected at a later stage, which makes it a little bit difficult to manage. And this is a very classic description of these cells, which are arranged in these lines and very planar fashion of growth. And so this is how invasive lobular carcinoma looks on pathology. Now, we are classically used to describing breast cancer based on histological subtypes, such as ductal, lobular, you have DCIS, and then you have invasive ductal cancer, and the same thing for lobular carcinoma in situ, and we have invasive lobular carcinoma. So this is what typically we are used to. But if you really go down and try to assess how breast cancer develops from the structure within the breast, there are two different types of cells that we see. One is the basal cell, which is the pink cell, which is lining the basal membrane, and then the luminal cell, which is responsible for producing the milk. This is the cell that responds to estrogen and progesterone, whereas the basal cell, which is this cell, is basically just used by the breast to pump out for the contraction, to pump out the milk, and therefore they don't really have any estrogen or progesterone receptors. And both of these cells are developed from a single stem cell, which we'll call the basoluminal cell. So if it differentiates into a luminal cell, it's called a luminal cell, and it can also differentiate into a basal cell. But basically, they originate from a single stem cell. So based on these features, the breast cancer is being classified in a different way, which has become quite standard of care. And it has also been included in the AJCC classification of breast cancer and staging manual. And so we now differentiate them based on their receptor status, such as luminal A, B, HER2 positive, triple negative, and so on and so forth. So in addition to some cancers being called invasive lobular carcinoma, they can also be differentiated further based on their receptor status and molecular behavior. Majority of the invasive lobular carcinomas are luminal A or B, which means they are ER positive and HER2 negative. They may be associated with genetic mutations such as CDH1, PTEN mutations, and so on. And more importantly, on pathology, they lack E-cadherin staining. So invasive lobular carcinomas basically cause inactivation of E-cadherin. And E-cadherin is a substance that actually is responsible for suppressing tumors. And so it leads to the inactivation of E-cadherin, which leads to the peculiar growth pattern that we see in invasive lobular carcinomas. They are less sticky, and so they just go along the planes. So E-cadherin is frequently associated with the lack of E-cadherin is associated with poor prognosis and survival in various different cancers. And so invasive lobular carcinoma is one such cancer. So here is an example of a ductal, invasive ductal cancer, which shows staining of the basal membranes with E-cadherin. And this is again a nice example of how the staining looks. And here is an invasive lobular carcinoma, and you can see the classic single cells arranged in a planar fashion, and it is negative for E-cadherin staining. So the basement membrane are not stained, and this is a classic appearance of a invasive lobular carcinoma. And these are just the normal ducts which the pathologists use as a standard in that particular slide to match against the rest of the tissue. And so this is normal staining of the ducts, and this is all the abnormal invasive lobular carcinoma. Another example, this is a lobular carcinoma in situ, and again, it shows lack of E-cadherin staining, and here is a control, which is a normal duct. This is how it should look, but there is no staining there. So this is the meaning of E-cadherin staining, and the fact that there is no E-cadherin used like stains in invasive lobular carcinoma. So that's a little bit about epidemiology and pathology. What about imaging findings? So mammography, the sensitivity of mammography varies in IDC versus invasive lobular carcinoma. And clearly the sensitivity is much lower in invasive lobular carcinoma. And I have here numbers up to 34% only. And as the density of the breast tissue increases, the sensitivity of mammography overall drops. And obviously it's further worse for invasive lobular carcinoma. So we have to be careful. 30% of invasive lobular carcinomas can be completely occult on mammography, and 35% are visible only on one view. So this is one of the hallmark features of invasive lobular cancers, that they may be seen only on one view versus both views. Tomosynthesis is known to increase the detection of invasive lobular carcinomas because it tends to pick up distortions, and it has been seen that it improves detection of invasive lobular carcinomas. Because of its peculiar growth pattern, detection may escape to much later stages. So on mammography, it may be presenting as a palpable finding. Here you can see a density, a partially obscured kind of distortion, mass in the upper quadrant, no calcifications. Here again, you can see distortion in the lateral, very subtle, but you see distortion in the lateral breast. And that's why it's important to assess carefully. Tomosynthesis will definitely help in such cases. And here is the example, same example showing the mass on ultrasound. So this is invasive lobular carcinoma. Here's another example which shows an area of distortion. There is some density seen here. You can see it in the CC projections. And here is the cancer after it's been removed from the body. And this is the specimen radiograph. So this is another invasive duct lobular carcinoma. It may present as an ill-defined mass, such as here in the upper outer quadrant. Some people may describe this as distortion associated with a focal asymmetry, but very indistinct kind of, there's not a mass, a classic mass that you may not see. And sometimes it may be prominent on one projection more than the other. So it can also look like that. Sometimes it presents just like a speculated mass, and then there's no differentiation between invasive lobular carcinoma or ductal cancer on mammography. And here is a more kind of focused view, a spot compression view. It may simply present as an asymmetric density, and for this you absolutely need comparison with the other side. And here's an example of an asymmetric density enhancing non-mass along the superior aspect of the right breast. It can present as a gradually increasing density. It may present as a gradually shrinking breast. This is quite classic appearance of invasive lobular carcinoma, and you can see on MR, it's a locally advanced breast cancer involving the nipple, quite extensive. Here's an example of a woman who was seen in 2010, and there was like a lentiform density that you see here, very kind of low density, no calcifications, no speculations, seen on prominently on MLO. On the spot compression views, nothing really jumps out. And the patient comes back in 2012. There's no change in the appearance. And in 2014, it grows. This is like so classic. This is why I always say that just because something is stable doesn't mean that it's nothing. So now it has grown after how many years? After 4 years. And now you can see it on ultrasound, and it was biopsied. And guess what? It was an invasive lobular carcinoma. Calcifications are very uncommon and may be seen associated with invasive lobular carcinoma, such as in this particular case, there are multiple pleomorphic, fine granular calcifications that are extending in almost like a linear ductal fashion. Very suspicious. This is obviously Byrod's 4B, and this is associated with invasive lobular carcinoma. Same patient shows extensive non-mass enhancement. Pretty extensive disease is demonstrated in the left breast. On excision, you can see the calcifications more nicely, and obviously they look very, very ugly. I mentioned that you may see cancers presenting only in one plane. Here is an example of a mass seen only on the MNO projection. You really can't see it well on CC view, and here you see a classic mass. And it may be occult, such as in this case, dense breast tissue. MRI shows multiple lesions, ultrasound shows multiple lesions, completely missed on mammography. So these are the multiple findings that you see with mammography. Here is an example of how a tomosynthesis image shows cancers very nicely. And this is true for invasive lobular or ductal. It does show speculations, and lesions do tend to jump out. And here it is how it looks on contrast enhanced mammography. It may show up as an enhancing mass, but what is more important is invasive lobular carcinomas may present as very low density, kind of minimal enhancement, and it can be missed on CEM as well. What about ultrasound? Ultrasound is more used as a diagnostic tool. It's used to perform biopsies, and it is used for in women who present with a palpable finding, negative mammograms. And again, the sensitivity varies from 68 to 98%, very operator dependent. We all know that. Invasive lobular carcinoma will present as a hypoechoic mass with shadowing. It may only show diffuse shadowing, and you may not be able to see the mass at all. It may present as a well-circumscribed mass in about 13%. Subtle lesions, this is very subtle, maybe hard to detect. 10% will be occult, and this is pagetoid spread, where the cancer actually is extending through the ducts, extending towards the nipple. So varied appearances, and you really need to have a high concern for finding these lesions, particularly post-MRI lesions can be very subtle. This is an ultrasound finding which is typical for invasive lobular carcinoma. This is called the picket fence or the Golden Gate sign, which you see associated with invasive lobular cancers. These picket fences are like perpendicular to the surface of the cancer, and this is quite classic. You can sometimes guess on ultrasound what the pathology can be. Role of MRI. What is the role of MRI? We know MRI is very sensitive. We heard a talk on preoperative breast MR and what is the use of MRI in detecting, staging for breast cancer. What is the impact on the re-excision rate, and the fact that it leads to more mastectomies and other over-treatment and over-diagnosis. But it is definitely one test that should be offered for any newly diagnosed invasive lobular carcinoma. This has been proven beyond doubt. It is one of the key indications of preoperative breast MRI. Perfect example, case here presents with a palpable finding in the inferior breast, nothing really seen on mammography. Ultrasound shows a suspicious mass. and MRI clearly shows the extent of disease. And so it's very important to assess invasive lobular carcinoma. It's also good for assessment of the contralateral disease, we know that, and obviously in the neoadjuvant setting. So on MRI, invasive lobular carcinoma can present as an enhancing mass, which is the commonest non-mass enhancement in 20 to 40%, which may be ductal, segmental, regional. Sometimes you may get slow enhancement with delayed washout, very much like a benign lesion. And sometimes you may even miss invasive lobular carcinomas in women with MRI. This is a lesion that presented as a mass. This is an invasive lobular carcinoma, which actually presented with a large palpable axillary mass, and that's how this cancer was actually came into light, and this is how it looks on ultrasound. Here is an example of a palpable mass. This is a tomosynthesis, which shows a spiculated mass. There's a associated round soft tissue mass associated with the spiculated mass, and plus we see additional findings in the further upper quadrant, some calcification. So extensive disease, very nicely depicted on tomosynthesis. But when you see the MR, it's further extensive, involving the entire lateral quadrant. So MRI does show a lot of extra disease that would otherwise be missed and would impact management. What about pleomorphic invasive lobular carcinoma? We spoke about it briefly. This is a variant of invasive lobular carcinoma. You may see it about 15% times in all diagnosed invasive lobular carcinomas. They have a higher incidence of lymphovascular invasion, higher incidence of distant metastasis, tends to be multifocal, multicentric, usually requiring a mastectomy. And they're likely to be luminal B, and they may be HER2 positive as well. This is aggressive form of invasive lobular carcinoma. I showed you this example before, single lesion seen on ultrasound, and this is how it looks. And this on pathology was a pleomorphic cancer. Here is an example of another pleomorphic invasive lobular carcinoma, very, very aggressive, involving the skin, fungating out, involving the soft tissue muscles, the pectoralis and the chest wall muscles, very aggressive. And this is a CT showing the same. So how would you manage invasive lobular carcinoma? Potentially, because of its extent, multifocality, the fact that it presents late can obviously impact how you would manage invasive lobular carcinoma, but it's known to have a lower frequency of axillary nodal metastasis, which is a favorable, situation for management. And the difference can be anywhere from 3 to 10% if you compare invasive lobular carcinoma to invasive ductal carcinoma. Distant metastasis can be seen, and they are quite unique. They can go to the ovary, they can go to the uterus, serosal cavities, even the meninges and the bones. So very unusual type of metastasis can be seen with invasive lobular carcinoma. Surgery, hormonal therapy, radiation, chemotherapy, standard array of management is offered for invasive lobular carcinoma. And like I told you before, if you match it with the stage, the outcome is identical. Higher percentages of invasive lobular carcinoma are luminal A, which means they're ER, PR positive, and so they benefit from adjuvant hormonal treatment. Conversion of wide local excision to mastectomy because of positive margins after re-excision is a likelihood in invasive lobular cancer. And that is why we want to do an MRI, because we want to depict the entire extent, which may not be possible with mammography and with ultrasound. Those of who are treated with neoadjuvant treatment also can end up in the same situation that they may require conversion to a mastectomy. Radiation obviously is given as adjuvant treatment. So this is just briefly how you would manage invasive lobular carcinoma. And then I want to touch upon this aspect as we end is lobular neoplasia. So what is lobular neoplasia? Atypical lobular hyperplasia and lobular carcinoma in situ together are called lobular neoplasia, and they are akin to pre-invasive. They are considered to be high risk lesion, and LCIS is similar to how you have DCS, although the implications are completely different, but this is lobular carcinoma in situ. It fills up the entire lobule with these uniform, bland kind of cells. And so what is the implication? There is increased detection nowadays. Why? Because we have better imaging modalities such as mammography, ultrasound, MRI. We are using more and more breast imaging techniques. There are women who are getting high risk screening, and so these may be detected on high risk MRI screening. And we talk about them a lot because there is lack of consensus. Pathologists have lack of consensus on the diagnosis aspect. Surgeons have a lack of consensus on management, and so the radiologists fit in somewhere here, and it's very confusing what recommendations are to be given to women who are diagnosed with lobular neoplasia. In any case, these are considered to be high risk lesions and they should be managed as high risk lesions, which mean they may require further genetic testing, they may require some high risk screening strategies, they may require risk reduction strategies. Usually, lobular neoplasia is multicentric and tends to be bilateral, seen in premenopausal women, and the upgrade rates can be as high as 67%, especially if they present as enhancing lesions on MRI. The risk of breast cancer is anywhere from 10 to 20%, and it is higher, obviously, in the ipsilateral breast. So you have to understand that this is a high risk lesion, which means it predisposes for the woman to develop breast cancer not only in the same breast, but also in the contralateral breast. And it may not be lobular, it can also be a ductal cancer, right? And it can also act as a precursor. The long-term follow-up of not a huge number of 252 patients showed that 68% had ipsilateral cancer and contralateral cancer was seen in 24%. So basically, it is a risk factor for both breasts as well as being a direct precursor. So that is a known fact. Here it is presenting as calcifications, magnification views. Biopsy was performed on stereotactic core biopsy. It was atypical lobular hyperplasia. Here's another woman who presented with a palpable mass with some calcifications. You can see a suspicious looking mass, which is quite stiff in the right breast. MRI was performed. MRI shows similar findings. And this was a large duct papilloma with atypia and ALH and LCS on excision. So there was no huge upgrade. Pleomorphic LCS is very, very high risk. It's very aggressive, and it is seen if you have a diagnosis of pleomorphic LCS, there is 45% likelihood of associated invasive lobular carcinoma. What does that mean? Every time you have a diagnosis of pleomorphic LCS, you have to excise it. Here is an example of LCS that is seen. And again, remember, there is no E-cadherin staining. It's negative as opposed to this, which is positive in DCIS. So that's a DCIS, and this is LCIS. Here's a woman who had 2 prior benign lumpectomies, calcifications in the left breast. Stereotactic core biopsy revealed a good number of calcifications, pleomorphic LCS. MRI shows more extensive disease, very concerning for invasion based on its appearance, irregular, involving the nipple, and on excision. Indeed, it was a pleomorphic LCS with invasive lobular carcinoma. Lobular neoplasia can present as calcifications or masses. I showed you some examples. Ultrasound, it can appear as a mass. It can be associated with other solid lesions such as fibroadenomas, papillary lesions. On MRI, it can present as a mass, non-mass enhancement, or can be completely negative. So these are the imaging features of how lobular neoplasia may present. So what is the role of MRI? Just to summarize, what is the role of MRI? These high-risk lesions can be detected on MRI performed for some other reason, right? So you perform a high-risk MRI, you see enhancing lesions, enhancing non-mass enhancement, and you diagnose lobular neoplasia, right? There is no specific features that really predicts upgrade, but the upgrade rate is pretty high for lesions detected on MRI, right? Then you may have a biopsy performed for findings on ultrasound or mammography, and the diagnosis comes back lobular neoplasia. These women then become high risk, and then they go on to have MRI for further screening as high-risk lesion, right? We also perform MRI to exclude invasive disease. So you may perform an MRI for somebody who's diagnosed with lobular carcinoma in situ to make sure that there's no other finding, particularly in pleomorphic LCIS, right? So you may perform MRI prior to surgery. And of course, you may perform MRI for high-risk screening. So once a woman is diagnosed with lobular neoplasia, she falls into a high-risk category and will come back for routine MRI screening. So just to summarize what we discussed epidemiology and pathology considerations of how lobular carcinoma, invasive lobular carcinoma is very unique, spreads in a very unique way, which makes it very difficult for detection on imaging findings. We looked at multimodality imaging appearance of invasive lobular carcinoma. We touched upon how MRI is important to assess invasive lobular carcinoma because of its unique pathology and a unique way that it grows. And sometimes it can be occult on all imaging modalities. We briefly talked about how invasive lobular carcinoma is managed. And then we also touched upon lobular neoplasia because it's very tied in with invasive lobular carcinoma, and the fact that pleomorphic LCIS is very, very high risk and is almost associated in about 45% with invasive lobular neoplasia. We looked at its implications and how they make an individual high risk and how they may require further high risk screening associated with it. Not only is a high risk lesion, but it's also precursor lesion, and it ties in very closely with invasive lobular carcinoma. So I hope that was useful, and I'll be very happy to take any further questions. Thank you very much for having me here. It's been a great pleasure to talk at the 13th conference in Egypt, and I'm really thankful for this opportunity.
Dr. Sahar?
Thanks, Professor Kulkarni, for these presentations. Actually, I would like to add that she's the author of Breast Imaging Essential Case-Based Review that was published in 2020. I'm very fond of your talks. Every time a question pops up into my mind, I found the answer in the upcoming slides. Thank you very much for this to the point and the informative talks. Please, Miret, will you start the discussion?
I have a few questions from the audience, but let's start with a question from panelists and the chairperson. If Dr. Aisha or Dr. Sahar or Dr. Bahira would like to address any question to Dr. Kulkarni. Dr. Aisha, we can't hear you. Still no sound. Still we can't hear you, Dr. Aisha.
Yeah. Professor Kulkarni, you said that the use of MRI in post-mastectomy and reconstruction in BRCA1 and BRCA2. But what about the use of MRI as a screening for early detection of breast cancer in BRCA gene mutations and variants?
Yes, so that's a very good question because women with gene mutations such as BRCA1, BRCA2 carriers, other high-risk gene mutations such as neurofibromatosis, PTEN, all these women fall into the high-risk category and they actually qualify for high-risk screening with MRI every year. So they should receive MRI screening.
Dr. Sahar, do you have a question?
Miret, proceed with the audience, please.
Okay, I have some questions from the audience. First, some asking about the functional MRI. regarding the ADC values in correlation with Ki-67 in luminal cancer. Do you include this in your reports? Another question about functional MRI is, do you use MR spectroscopy in breast report?
Okay, so thank you for those questions. And so as you realize, this Ki-67 and these parameters, they're used to as a prognostic tools by pathology results. So they are like pathological tests for those of you who just I want to update them. And they are used as a predictor for proliferation. Ki-67 basically indicates that the tumor is proliferating fast. So if you have a score of, let's say, more than 20%, then it means that this cancer has a very high proliferative index. And what it really is a predictor of is how the cancer is going to respond to neoadjuvant treatment. Because as we know, fast growing cancers respond to chemotherapy because there are many cells that are rapidly growing, and usually chemotherapy is targeted. So all the neoadjuvant treatments are targeted towards this. There have been some publications which correlate the ADC values with the Ki-67 values, and there are papers which say both ways, that there is a huge degree of overlap in the ADC values for benign versus malignant, and even within the malignant, low grade versus high grade tumors. And there are some papers which describe good correlation between ADC values and Ki-67. The bottom line is we cannot use MRI to detect Ki-67 values. MRI features, the temporal features, spatial features, functional features are all just ways to make our reports or results more comprehensive and meaningful to the referring oncologists and surgeons. But values of Ki-67 is something that has to, it is something that is given by the pathologist. We are not going to report Ki-67 values based on MRI. So remember, it is a correlative technique. So although we can predict high risk features, we can predict local spread, we can predict some features which indicate that this is an aggressive tumor. Yes, we should report that, but it should not reflect on pathological values. So we have to be very careful not to overstep what we are expected to report versus what we say. And many times you may not even have the Ki-67 values at the time that you do the MRI. You may or you may not have it. So you can definitely correlate, but it is not a standalone test to predict such parameters such as Ki-67. So I hope that that helps you. Also remember that diffusion and all these parameters like the ADCs, they're very, very sensitive, and technique is very important. I have seen many images which are very suboptimal, but radiologists tend to overread into these ADC values. It doesn't change anything, because as long as have a biopsy which proves that there is invasive disease, everything else is just staging as far as imaging is concerned. Yes, we like to be very specific, but quality of ADC is very important. And I always like to caution radiologists not to overread into what information we have on MRI. It has to be meaningful to the management. It has to guide management, and it has to put everything together. I always tell people that when you report a staging MRI, it's a story. You have to tell a story, and what is the end of the story. And you put everything together, that you have the pathology findings, the Ki-67, everything comes all together in the end, and you give management guidance. So that's how I like to report. MRS, I have not seen any reports, at least in our setting, that we don't do MRS, because it's the same thing. It is very difficult to perform MRS for breast because of the unique nature of the technique. Like the patient is lying prone, there's movement with breathing, there's the breast is hanging. So MRS is also very difficult to perform on breast. However, if you have a good setup and your MRS is good in the way you do it, for sure you can report it. But it's not like is done in neuroimaging. Remember, neuroimaging, the brain is inside. You don't have easy access to it. The breast is very different. We have such easy access to biopsy, needle procedures, multiple techniques. So it's very easy to get tissue as opposed to a brain. And the brain is a stationary object. So the MRS that you see in neuroimaging is much more robust than what you see in breast imaging. Yes, you feel free to report it, but remember, nothing replaces tissue diagnosis. So all our efforts should be at coming to like a proper management plan and diagnosis, which is meaningful to the patient's treatment. So that's my opinion about how to use these fancy things. They don't make a huge difference, because unless your primary reporting or your primary information is robust, all these added features such as ADC, MRS, and so many different things, they will not make any sense if your basic reporting features or findings are not included. So I hope that helps, Merit.
Yeah, very nice, very interesting comparison between breast and brain. We have more easy access to tissue, while we have more access to functional inside the stationary tissue inside the brain. Thank you. I have a question regarding staging, lymph node staging. Is level 3 lymph node, do you consider it's the same as infraclavicular node? In another word, do you consider level 3 as N3?
Yeah. So very good question, because often there is confusion about lymph nodes particularly in the management of breast cancer, and our role as radiologists and how we should actually report them. So this question, just for everybody, I'll just repeat it. Is level 3 lymph node the same as N3? So first, it is important to understand the difference. What is the difference between a level and what is the difference between stage, right? So that's what we are trying to understand. So when you talk about levels, it is an anatomical description. Where is the lymph node actually located? And when you talk about N1, N2, N3, that's actually the stage. So we take all the anatomical information that we have and put it together in a more meaningful and prognostic stage that will impact management. So if you look at levels, as I mentioned in my talk, the levels are described based on the position of the lymph nodes with the pectoralis minor. So any lymph node that is lateral to the pectoralis minor is a level 1 lymph node. Any lymph node that is behind the pectoralis minor is a level 2. Any lymph node that is medial to the pectoralis minor is level 3. Level 3 lymph nodes are still infraclavicular. So they are quite high up, but they're still below the collarbone, below the clavicle. So those are the level 3 lymph nodes. Supraclavicular lymph nodes that are above the clavicle, are not part of the levels. And if you have a supraclavicular lymph node that is positive, that's actually M1. So remember, it's very different than just local staging. So positive lymph node, like we know the Burkhardt lymph nodes, supraclavicular lymph nodes, those are considered to be M1 lymph nodes. And it's the same for breast cancer staging. And so when you look at the stage, the lymph node stage, N1, N2, and N3, N3 is also divided into 3 different subtypes. So when you talk about your level 1 and level 2 lymph nodes, they come in N3A and N3B. When you talk about N3C, they consider lymph nodes that are also above the clavicle. But definitely supraclavicular is considered to be M1 also. So it all depends on where the lymph node is located. Intramammary lymph nodes that are usually located in the lateral breast, for the stage, for the purposes of levels, that's considered level 1. And internal mammary lymph nodes is a completely separate category. So they don't come in the levels. They have to have a separate mention, and they have to be addressed separately. One of the important things is the internal mammary lymph nodes are mentioned separately because they don't actually impact treatment. Because very rarely would a surgeon go in and remove internal mammary lymph nodes. When you report internal mammary lymph nodes, there are two things. One, it's very difficult to actually get histological proof that they are metastatic, because fine needle aspiration and biopsy in that area is very difficult, and it may not be possible. And the second thing is, when you report internal mammary lymph nodes, that is the information that is used by radiation oncologists, because they will decide where and how the radiation field should be so as to include the internal mammary lymph nodes. It's not something that the surgeon is going to chase, right? Unless it's a big, obviously it's a big mass, but so it's important to understand the implications of where these lymph nodes are located. But just to summarize, infraclavicular lymph nodes are all level 3, and N3C can have lymph nodes that are above the clavicle. So I hope that helps. So there should not be confusion between levels and the N stage.
Staging. Do you have any special report regarding the rotor lymph node? Do you mention it in the report?
Yes, we always report. Yes, and Dr. El Mahdi definitely remembers this, that we do report any lymph node between the muscles, between the pectoralis major and minor. There's a small space. Normally, there is nothing in that space. They are just stuck together. But sometimes a little space is created in there, and there may be a lymph node there. It is still a level 2 lymph node. A Rotter's lymph node is a level 2 lymph node, but it has to have a special mention, because I always describe this, that we see lymph nodes so nicely on MRI, but when the surgeon goes in, it looks very different. They're like these tiny lymph nodes in a whole area of fat, and it's very difficult for them to look for the lymph nodes like we look for them. So any lymph node that's deep, any lymph node that's in the level 3 or in the Rotter's lymph node space has to be specifically mentioned in the report, so that when the patient has surgery, that lymph node will be addressed. And if that lymph node is not removed, it will definitely lead to treatment failure. Cancer will grow in the muscle directly, and that's very bad for the patient.
So you put rotor lymph node in the report,
yes.
different than
yes.
Yes. Great. And intramammary lymph node.
Intramammary lymph node,
also...
it should be mentioned separately, because remember, intramammary lymph nodes are part of level 1, so they can actually be your sentinel lymph node. And if there is a low intramammary lymph node that's abnormal, we usually will localize it separately with a wire for the surgeon, because that lymph node could be your sentinel lymph node. And yeah, and if the surgeon doesn't scan low enough, they may miss it. So any guidance, that's our job, to give guidance to make sure that there is appropriate surgical management. So if you see any low lymph node, you may biopsy it, prove that it's metastatic, or prove that it's not metastatic. And if it needs to come out, it requires special localization, because it's not easy when the patient is lying in the OR to look for intramammary lymph nodes. The surgeon can't actually just go in and find it. Like we see it very nicely on mammography or ultrasound. So you have to localize it separately if it is abnormal.
So if you have an intramammary lymph node, you biopsy it before the operation, and it came out back as malignant. Does that mean the surgeon will go for dissection, go for axillary dissection?
No, it's still a level 1. That theory that you require extensive axillary dissection is gone, right? Even with the 2 or 3 sentinel lymph nodes positive, surgeons will not go in to do a complete axilla. There's so many different considerations now with the ASCO Z11 and then subsequent trials in the neoadjuvant setting. So the management of axilla is again very personalized. Again, it's called a targeted axillary dissection. So if you show that there is a lymph node positive, then you mark that lymph node for the surgeon in any way, like wire localization or whatever technique you're using, and they will additionally do a sentinel lymph node biopsy. That's called a targeted axillary dissection. So you're removing the target lymph node and you're adding sentinel lymph node biopsy. So that allows the surgeon to minimize axillary surgery, because that has a lot of morbidity for the patient. Like removing axillary lymph nodes can be a total disaster for the patient's overall arm physiology, and there's so many different problems that they have following axillary dissection. So yeah, so if you have you can do a targeted axillary dissection and localize the lymph nodes that are positive. Of course, when you get to 2-3 lymph nodes being majorly abnormal on imaging, you have to think like, you can't just get away with removing just 3 lymph nodes if they're grossly abnormal. But these, what I'm talking about is smaller lymph nodes, single abnormal lymph node in a slightly variant position. So this is how you manage.
Regarding surveillance, how do you do post-breast cancer surveillance for patient developing breast cancer in early 20s? Do you do mammography or just ultrasound? And also another question for surveillance, does this mean don't use MRI in staging routinely, only in selected cases?
So I'll address the first question. The first question is women who get breast cancer in their 20s, and there are such individuals young people who are susceptible to multiple cancers. And what is happening now is these childhood cancers are being treated so nicely that these women, these young girls, are now getting into adulthood, but they're still prone to having cancers. And one classic example is Lymph syndrome, the P10, genetic aberrations that they predispose young people to multiple cancers. And you do get these girls who become, in their 20s, they may get breast cancer. Usually, if a woman is getting breast cancer at that early stage, there is usually bound to be some kind of genetic predisposition, some high risk that needs to be investigated. And these women, because they're so young, will benefit from MRI screening. So we do have a subpopulation of young women with breast cancer, history of breast cancer. They get MRI screening and not ultrasound or mammography screening, because the yield of information is the highest with MR, and they are high risk, so they should get MRI screening. If you don't have access to MRI screening, then ultrasound is a good way. But offering mammo starting at age 20 is a little bit harsh. But if it is required, it should be done. Yeah.
Sure. Last question. Please, I need more clarification from regarding lobular LCIS presented as papillary lesions. Clarification regarding LCIS presented as papillary lesions.
Yeah. So there was another question that I didn't address. I just addressed the young cancer patient. I think the other sub question was, should MRI be not offered for all women with breast cancer for staging? And I think we discussed that in my talk, that if you have the facility to offer MRI staging for everyone, for sure you will get more information, but then you'll also get more false positives. You will get more workup, more MR biopsies. So if your facility is equipped to do all of that, for sure you can offer MRI to everybody that comes your way. We don't have that luxury, like we are restricted in how many MRIs we can perform, but I personally do believe that it does help. So especially in younger people with dense breast tissue and new diagnosis of cancer, these women will definitely benefit from MRI staging, and we do offer it to quite a few of our own patients if possible. If the breast tissue is fatty, doesn't matter. If the patient is already chosen to have mastectomy, then you don't need to offer an MRI. So you have to see what resources are available, but there are some indications for whom you should definitely offer MRI, and we discussed that in my talk. And just to briefly summarize, invasive lobular cancers, high risk individuals, women who present with dense breast and invasive disease, women who have prior high risk history or prior breast cancer. And then you have women who present with non-calcified DCIs in a dense breast tissue. So these are the few areas where you would offer MRI staging for sure. And then the last question was about lobular neoplasia, and more specifically about LCIS and papillary lesions. So lobular neoplasia can occur with any other high-risk lesion, or it can present in papillomas, it can present in fibroadenomas. So they can be associated with other breast lesions, and depending upon how they are presenting, you will suggest management. Not every single ALH needs to be excised, not every single LCIS needs to be excised. And there's a lot of controversy around how to manage these high-risk lesions. But generally, anything that is presenting as an abnormal birides feature, anything that is presenting as microcalcifications and you don't know what it is, anything that presents as an enhancing non-mass area or a enhancing mass on MRI, those are the high-risk ones which you would consider excision. Generally, in our setup, we discuss all our high-risk lesions with the pathologist and then come together and decide on a consensus which patient should go for excision. There is a lot of literature which is confusing. Some people excise, some people don't excise. The most recent one that I looked up, they said that you should excise any high-risk, lobular neoplasia. So it's really still up in the air.
Thank you so much, Dr. Kulkarni. It was a wonderful session. Thank you for the excellent talk, very informative discussion and information. Precious. One more thing before ending the session. There is one important thing that I would like to inform you about, that BGI
Wow, happy birthday!
SBI wish you happy birthday, many happy returns, and we wish you were here in Egypt so we can celebrate it here. Maybe next year you will be with us here in Egypt.
Yes, happy birthday.
Yes, it's your conference is always around my birthday.
Yes, it's always every year it's around your birthday in end of January. Yeah.
Yes. Yeah. Thank you so much.
I was just saying that yesterday, that when you accepted to come, it became virtual.
Yes.
But we're waiting for you next year, inshallah.
Yeah, we were looking for you are with us this year.
Yes,
I'm looking forward to traveling again, anywhere for that matter, right now, but I haven't left the country for 2 years. It's pretty interesting. It never happened to me before. But thank you so much for having me, Dr. Rasha.
No,
and
we should thank you. Yes, the lectures were extremely interesting. Yes.
Yes, and actually, Dr. Alad here also. She's attending the birthday.
Yes.
Hi, Supriya. Wish you a very happy birthday.
Yes. Hello,
hey,
hello, Shilpa.
Hi, Rasha. Hi,
hello.
Hi.
Good to see everyone.
Your talks. Yeah.
Yes, thank you very much. It's a big pressure after you have spoken, Supriya. These are big shoes to fill in.
And thank you for switching the timings with me. I know it was very last minute, but
hey, no worries. That's a small thing.
Shilpa, you want to change the name to Shilpa Lada right now? I see Agasti.
Oh my God. Yeah, Agasti. Yeah, I don't know how to do that. And I have no idea why that has happened. But yeah, I suppose we can go with Agasti Lad if I can't change the name.
Okay, just go to the top and
rename. Yes, rename.
Yes,
okay.
Thank you.
Yes.
Thank you, everybody.
Thank you, Dr. Supriya. Everybody here in the streaming studio wishes you also a happy birthday. Now we end the streaming of the first session of the second day, and we will back again for live streaming in 2 minutes. Thank you all.
Thank you.
I want you to know that no matter where you are in life, no matter how low you have sunk, no matter how bleak your situation, this is not the end.